Okay, let's talk about Rh negative pregnancy. First, incidence of Rh negative individuals. 5 antigen is very important. So they are coded by two genes RSD and RSCE. Both genes are located in the certain chromosome. D. Positive individual may be heterozygous while heterozygous is 50. Suppose the father is homozygous Rh positive. Okay. So here is homozygous, so father is D and D, mother is Rh negative, so there is no D antigen. So in germ cell D, one D will come and D will, if it is if it is there met, there will be chances of positive DO, that is fetal Rh positive, and here if father is heterozygous, this is homozygous. If father is heterozygous or is positive, then there will be, here it is 100% positive, 100% chances of the, if father is homozygous or is positive, there is 100% chances of RS positive baby. If father is heterozygous or is positive, there is 50% chances. Okay, then high risk pregnancy, because RS negative pregnancy are all high risk pregnancy due to risk of alloimmunization, fetal anemia, iron, fetal anemia, hydrops, and the high risk pregnancy due to risk of alloimmunization, fetal anemia, hydrops, and adverse perinatal outcome. Alloimmunizations, persons develop antibody to antigen that is derived from other individuals. So allo, if it is same, then it is auto. If the own body, that is autoimmunization. Careful monitoring of the women and unit. All pregnant women should be screened for blood group and RH negative, RH antigen. If negative, advise ICT and husband blood group and RH blood group and A. Then there is due positive and due negative. D antigen positive, D antigen partly. What is the pathophysiology? The first pregnancy, the D negative mother is Rh negative, but baby is Rh positive. In first pregnancy, there is the antigen, there will be the anti Rh negative mother. She is just, in second pregnancy, there will be a sensitization happen. Already sensitized mother, she developed IgG antibody that can easily cross, but initially in the first IgM antibody that can cross the placenta. Fetal hemorrhage. Suppose there will be fetal hemorrhage, antibodies form are IgM type weak, takes 6 weeks to 12 months to from the IgG antibody. Anti-D, here fetal antibody already formed, that is IgG type, that it easily cause, that is called hemolysis. Now the hemolysis lead to anemia, that will cause stimulation of the erythropoietic response, that will cause bone marrow erythroblastosis fetalis and extramedullary hematopoiesis, that is called hepatosplenomegaly, hepatic dysfunction and portal hypertension. When there will be hepatic dysfunction happen, there will be reduced synthesis of protein, that will cause decreased colloidal pressure, colloidal oncogenic pressure, that will cause ascites. The portal hypertension cause increased hydrostatic pressures. Then when there is anemia, that will cause hypoxemia and that will cause release of catecholamine. That catecholamine cause increased blood flow to the brain and decreased blood flow to the liver and kidney. As increased blood flow to the brain, that will cause increased mid systolic MCA, peak systolic velocity, and decreased blood flow to the kidney, that is activate the RAS system, renin angiotensin activator system, cause salt water retention, that is cause hydrops in the baby. Then umbilical, when the anemia is called heart failure, umbilical venous pressure will increase, hydrophic changes seen in placenta, causes placentamegaly. Fetal-maternal hemorrhage can occur at any time. Frequently and magnitude of fetal-maternal hemorrhage increase as pregnancy advances. As little as 0.1 ml fetal hemorrhage is sufficient to cause sensitization. Although sufficient amount of fetal-maternal hemorrhage occur at the time of delivery in 15 to 50% cases, but only 10 to 15% develop immune response. Usually it is dependent on the insufficient passes of antigen, maternal antibody, variable antigenicity, and maternal immune response. It depend on maternal immune response. ABO incompatibility is protective because of ABO incompatibility there will be lysis of the because of ABO incompatibility that already lysis the fetal RBC. So there will be less exposure of the fetal RS positive antigen to develop antibody. So risk of alloimmunization, that is 16% of ABO incompatibility, 2% of ABO incompatibility. What are the causes of fetal maternal pregnancy, like abruption, ectopic pregnancy, fetal death, procedure like amniocentesis, chorionebular sampling, fetal blood sampling, molar pregnancy, evacuation, APH, threatened abortion, delivery, external separation, trauma to abdomen. Then determining the epidemiology, how will you calculate? The risk factor is young age, assisted vaginal delivery, cesarean delivery, post-mature to determine the dose of antibody development. Okay. Clear kit test will do. Smear from maternal blood will add acid. Fetal red cells are resistant to acid. Then you stain. Fetal cell, you should count the fetal cells are counted divided by 1000 Go cells into 5000 ml of blood is equal to. They determine the between the Rosette test and KB test. Rosette test is a qualitative test, KB test a quantitative test. Here antibody is present or absent. SUG recommended is at initial test. So maternal blood incubated with the anti-D followed by indicator is added. Fetal RBC resistant to acid. Then continue flow cytomorph not easily available. Then RSD negative, how antibiotic management. RSD negative pregnant women. Okay, then how will you go further? First, you will do husband blood group, RS blood grouping, and RS typing. If and past history of mismatched transfusion history is there or not, you should ask. Past obstetric history of any like including MTP. Then husband blood group is come as negative, so nothing active intervention is required. Then if your husband blood group is positive, then you go for a ICT test. If it is ICT is negative, okay, husband blood group has to do. If ICT is negative, that is non-sensitized. If ICT is positive, you should go for a titer assessment, critical titer that should be done. Then critical titer is variable. Usually it is 1 is to 116. Titer above which there is significant risk of developing anemia and hydrops. Okay. Indirect test. Most sensitive and reliable to determine the presence of degree of alloimmunization. Then D is non-sensitized. If it is RH non-sensitive, you will give injection anti-D at 20 weeks. Then at term, cord blood has to be investigation. If baby blood group is positive, and administer injection anti-D. Routine administer anti-D prophylaxis. Incidence of RH immunization before 28 weeks is less than 1%. At 28 week to third trimester, alloimmunization is developed to increase 2 to 1.1%. To prevent antepartum alloimmunization, routine intervention will prevent events of maternal hemorrhage. Half-life usually 16 to 24 days. Provide all protected till 12 weeks. Dose is 300 microgram or 1500 international with 30 ml of fetal blood and 50 ml of fetal RBC. Remember, 30 ml of fetal blood, 15 ml of RBC. Within 72 hours, decrease the risk of alloimmunization by 90%. May provide protection up to 28 days. If delivery within 3 weeks of full dose and fetal maternal hemorrhage is less than 50 ml, the postmortem dose may be omitted. If the last dose within 3 weeks, then postmortem dose will be omitted. And fetal maternal hemorrhage is less than 50. Despite giving 0.21 women develop antibody. In miscarriage, to all complete and incomplete spontaneous threatened miscarriage after 12 weeks, If it is less than 12 weeks, not repair if no instrumentation has been done. All cases where surgical evacuation is done. All induced abortion 50 microgram before 19 weeks plus 6 days and 100 microgram after 20 weeks. 50 is before 12 weeks, before 19 weeks plus 6 days. After 20 weeks, you will give 100 microgram. All ectopic and molar irrespective of management. Anti-immunoglobulin to prevent hemolytic digital pneumonia may be polyclonal monoclonal antibody. Polyclonal is recommended. Sterile concentrated solution gamma globin containing measure amount TD antibody obtained from pooled fraction plasma. Monoclonal is synthetic. Passive immunoglobulin, and after anti injection the titer is less than 1.4 or more than 1.4. Failing titer and rising titer. Antipatam desensitive antibody titer we will do if it titer is less than critical titer or titer is more than critical titer. If it is titer is less than critical titer, then you have to repeat this every 4 weeks till 28 weeks, then every 2 weeks, then serial alteration has to do induction of lever at before 40 weeks. If more titer is more than critical titer, there is no role of repeating the titer. Remember, the if titer is less than critical titer, you have to repeat because you have to achieve. You have to be aware when the titer is crossing the critical titer. If you have to repeat every 4 weeks till 28 weeks, and then every 2 weeks till every 2 weeks. Then serial alteration has to do for poly any hydrops oil before 40 weeks. Then if it is titer is already crossing the critical titer, no role of repeating the titer. You have to do a monitoring of the MCA-PSB weekly, NST and ultrasound for hydrops. Feature of fetal anemia and ultrasound, there will be hepatosplenomegaly, increased placental thickness more than 4 cm or more than 6 cm in second and third times respectively. Second is 4 and third times is 6 cm. Polyhydramnios, oligydram, fetal hydrosis, increased abdominal circumference, collection of fluid at least 2 remember the collection of fluid at least 2 compartment, that it can be a pericardial or it can be a peritoneal, it can be subcutaneous or pleural. Fetal ascites, earliest finding is fetal ascites. The skin edema, the skin thickness should be more than 5 mm. Remember, more than 5 mm skin thickness is skin edema. Fetal ascites is the earliest finding, at least 2 compartment, increase abdominal circumference, and more than placental thickness is more than 4 cm and the second and more than 6 cm third trimester in CAP. Feature of fetal anemia on ultrasound, there will be a skin edema. Remember here it is skin edema is there, and subcutaneous pleural edema is there. This is the scalp edema. Then when you are monitoring MCA-PSB, different for gestation sensitive predictive moderate to severe fetal anemia. If it is less than 1.5 mm, repeat weekly and deliver at term. If it is more than 1.5 mm, gestational is already 35 weeks, you will deliver. If it is less than 30 weeks, cardocytosis intrahepatic transfusion. NST and biophysically, sinusoidal pattern in fetal anemia. Other method, Lilly graph, this is not done. Cardiosynthesis, evidence of hydroxon ultrasound, MCPB more than 1.5. Fetal blood transfusion before 34 to 35 weeks. If hemoglobin is less than 80 gram and hematocrit is less than 30%. Umbilical vein is the route of transfusion. Becuronium is the relaxant. Transfusion of red cell, you can use type O, O positive, O negative blood group, cytomegalovirus negative, this is screen for CMV. Hematocrit approximately 80% to prevent volume overload. Irradiated to prevent fetal graft versus host action. Leukocyte poor depleted blood has to be given. Fetal blood transfusion, becuronium, intravascular more than intraperitoneal, early trimester, non-hydrophobic fetus. The target hematocrit is 40 to 50%. Volume of transfusion is dependent. The Kaha will calculate. Volume of transfusion will calculate by estimated fetal weight in gram into 0.02 for each 10% rise in hematocrit needed. Following transfusion threshold of MCA-PSB is 1.7 rather than 1.5. Hematocrit drop by 1% per day. Intrapartum management, you should inform the pediatrician. Blood should be cross-matched. Be gentle during the delivery and cesarean section and abdominal manipulation. Avoid uterine massage. Wait for spontaneous expulsion of fetus. Avoid avulsion of the cord. Avoid exposure of lacerated vaginal wound to cord blood. Early cord clamping should be done. Call it no. It is no early. It is delayed cord clamping. No. Collect cord blood. Postpartum management. Postpartum blood group, you do fetus blood grouping and DCT. If it is both blood group is positive, DCT is negative, we will do routine is not done. KB test whenever large bleeding is suspected. KB testing and anti-D is accordingly. Postnatal prophylaxis to reduce the risk of elimination 15% to 2%. Inform about anti-D administration. Risk factor for excessive postpartum hemorrhage. Postpartum pituitary hemorrhage like MROP, cesarean delivery, intrauterine manipulation, multiple gestation, PH, antepartum hemorrhage, abdominal trauma, stillbirth. Question: root dose, most common cause of amyloidic disease, avian incompatibility, in 20%. Leishmaniasis, anti-A, anti-B, IgM, fetal view, kale elimination. Grandmother effect. Some amount of maternal blood enters the fetal circulation in pregnancy. Fetus is affected by maternal antibody by a response initially provoked by grandmother. What is grandmother effect? This is the grandmother having, suppose the grandmother has O positive blood, okay. She has a Rh positive antigen, positive RBC. When he gave birth, is this baby, when this mother is in baby, this Rh positive antigen is exposed. Suppose this mother, she is her mom, okay. So when this mother is inside her uterus, this mother has been sensitized by this Rh positive blood of her grandmother, her own mother. So already this mother is sensitized to the positive antigen. So already her body has developed anti-D antibody. When this mother deliver a baby, her daughter is O positive. Already she sensitized, it causes hemolysis. Okay, this is very simple. Grandmother has a positive blood group, and when she deliver a baby with a negative blood group baby, the baby already exposed to the O positive blood group, so she already developed anti-D antibody. That will when she has become pregnant, if she had an O positive baby, then that will cause hemolysis in the first pregnancy itself. Okay. Myriad syndrome, placentalomegaly, high drops may cause preeclampsia, swollen mother, swollen fetus. Prenatal determination of fetal height type. Avoid unnecessary administration, routine antenatal administration. Intensive monitoring is not required. If you want to do fetal arrest type, there will be avoid unnecessary administration, routine anti-D prophylaxis. Intensive monitoring also not required. If amniocentesis is preferred over CBS, cell-free DNA may also be used. Not recommended by SUG. Accidental transfusion of D positive blood. 5 into antidote neutralize 4 ml B positive blood for each transfuse 50 microgram antidote should be given.